Approval of the minutes from June. Any additions, deletions, corrections from those?
There's a flat of cookies. These full-time rental post
Hearing none, we'll consider those approved. New business. We received documentation from Andy's Oneonta for a new medical director, Dr. Sosnow, Dr. Robinson. So those documents appear to be in order. Any opposition to those positions being service medical director? Dr. Robinson's active at Fox, and Dr. Sosnow is an emergency physician and internist with EMS experience from the Albany area, who's now in Delaware County, so he's proximal to the Andes squad. All right, hearing no opposition, we'll consider those approved. Schuyler Lake and Middleburg looking to begin intranasal naloxone. We have documentation from Schuyler Lake and Middleburg to do so.
Yes, I also have a letter. It came after I had put the agenda together. Came yesterday from West Exeter asking for Narcan approval.
Okay.
All three letters were signed by the respective medical directors.
All right. You never have enough Narcan. We'll get those approved. Pittsfield for BLS albuterol. I don't see documentation for that. Did they, the medical director sign off on that as well?
Yes, he did. Hang on a second. Yes, I have it here. I'm not quite sure why this was sent in to me because it was approved a year ago, but they did send me another one. So actually, we just take notice of it. It's already approved by the REMAC.
Okay. And for the record, West Exeter, I think there's actually Unadilla Forks, right?
Unadilla Forks, right. Unadilla Forks and West Exeter, yeah.
Okay. All right. So Pittsfield, BLS, albuterol, any objections to that? Okay. Next question is, can Saratoga become a STEMI? I don't know. Ask Cuomo.
I was requested to ask that question to the REMAC doctor, so...
we don't designate.
Oh, I know. I just wondered if you had any input about who's being designated and how it's being done, etc.
No. I don't know where the state, there's a cardiac advisory committee that advises the governor and the commissioner, and so it happens at that level.
They're not in the cardiac center currently,
right.
And for us in this region, for us to transport a STEMI patient there is kind of pointless. When they can do a cath, they have no intervention capability. So for us to bring a STEMI there, we confirm in the field is kind of foolish.
Where would you bring them?
We would bring them to Alice. Alice is our...
Did you receive a confirmation on what their capabilities actually were going to be?
As of the last I heard, there was no intervention. It was just
they don't have an
cath.
interventionalist.
They don't have an they are in the process of probably by the end of October. I was told by the administration from their facilities that they'll be able to handle any cardiac.
Which should be addressed if they have intervention services.
They will. They brought in 2 cardiologists for that specific purpose to become an interventionist. So,
But either way, we don't determine that.
No.
Actually, they themselves should probably make the first step in asking for designation, shouldn't they?
They have. They
Point
have.
was.
They have. They are in the process of becoming a PCS facility. They are not there yet, but they're in progress.
Okay. So somebody from some higher level will let the region know when they're so designated.
I'll probably pick it up through the REMO meetings I go to in Saratoga.
Yeah.
I mean, I see these two rather regularly.
I'm sure that as soon as a hospital is ready to accept more patients that are coming in via EMS, that they will do a fine job of letting us know that they're open and ready for us.
Yeah, I mean, the DOH does the designation.
Just saying.
It's like trauma designation. So Tom's point is like, they have to be designated before they match
There'll be a billboard.
protocol.
Right.
So at this point, no.
Say what?
Isn't that what Dr. Bell is?
I thought Todd left the region.
No, he's still in Remo, he's at Saratoga.
Who?
Todd,
Todd.
Duthaler.
Duthaler?
Yeah.
Yeah, it might be worth shooting him an email.
I'm gonna wait for Cuomo to send us a letter. Because it's a pretty formal process. Because they report data to the state of New York, they report data. So there's data reporting requirements, as well as CMS reporting requirements for balloon time, et cetera. It's not an informal EMS, REMO, AAREMS process. It comes from the Department of Health. Same as trauma designation. You can't just, we don't get to decide any times. All right, so sure, they become, I assume, if they cross all the T's and dot all the I's and get the approval of DOA. All right, so there's a suggestion, I guess, that we adopt Remo's intranasal naloxone reporting form.
I have a copy of it here for everybody, I think, among the handouts. This is it's kind of a plain vanilla form, and I distributed it on the 19th of August, and I sent it out again 2 days ago, just to make sure, because the summer hiatus is a lengthy one. So just make sure everybody had a copy of it. If the REMAC docs approve of it, we can put it on our website and make it downloadable on our forms and applications page, and folks can report their naloxone usage.
So these agencies that we just signed up for intranasal naloxone, this would be a requirement.
That they use this form. It would be a requirement for everybody that they use this form, right?
Including ALS agencies?
No, the BLS Narcan. Yeah, we're only talking about the current flavor of the month, intranasal Narcan by BLS providers and everybody else.
Is this still in sort of a demonstration project? You know, it's out there, it's everywhere. So why are we collecting data about something? What are we going to do with the data?
Not really sure, to tell you the truth.
Is that your deliverable for the year, Phil?
I'm sorry?
Is that your deliverable, your topic of study for the year?
I honestly don't know. I'd have to look at the deliverables. I haven't looked at the
Yeah, that was what we decided.
Yeah, that's why.
Right. Okay.
I was trying to refresh your
It's
memory.
going to be an awful easy deliverable to do, I'll tell you right now. The next
All right.
item will prove that.
That's
Oh, I had
still
one
interested
question.
in doing it? Like,
May I had one question in that, if an ALS agency uses the intranasal Narcan, an ALS provider uses that does not have to be reported, correct?
Right.
Just
That's my
if the
understanding.
BLS,
Yeah,
okay.
the BLS thing is the demonstration project statewide
Okay.
for everybody in sight.
So at this point, as far as I know, we haven't had any.
Right. You're
Okay.
right.
I know that ALS,
None have
you
been
know,
reported.
ALS has given it intranasal, but I don't know that. I'm keeping a pretty close eye on the PCRs.
Mhm.
To see if any come through, and the only one I've seen is an ALS provider.
Likewise, yeah, I QI the controlled substance PCRs in our 3 counties, and I've not seen it by the BLS.
So you'd be able to tell if the BLS agency used naloxone.
I'm sorry?
Your system would pick up naloxone use by any agency, including BLS.
Right, well, it would only pick up the BLS use if they gave us some kind of reporting form.
Or I spotted it.
Mm.
And the way documentation goes, very often, it may or may not even be noted.
Right. Theoretically, the ePCR system would pick it up. The state bridge would have it.
And and the one,
State bridge.
the one thing I wouldn't get is anybody using electronic. I wouldn't be able to pick that up. You
Right.
would.
I can pick that up,
Yeah.
yeah. More about that later, much more about that later. So what's your, I'm sorry, Tom had a question. I was just going to say, how do the doctors feel about this reporting form, but I'm going to,
Is there, so would they also fill out a PCR? They don't fill out PCR.
oh, the BLS squad will fill out PCRs.
So you have the PCR, which
Yeah.
has the vitals.
They should, if they administer some BLS meds, that's supposed to be documented in the PCR, yes.
If I spot one, what I plan to do is flag it and make a copy of it so that we have it. But so far, the only one I've spotted is an ALS agency.
Can I ask a
I've had
question
3 or
about the
4.
form?
I've had 3 or 4 in the last couple of months from ALS agencies, but only 3 or 4.
Can I ask a question about the form? If the form is for the naloxone administration, isn't question 1 redundant?
I'm sorry, I don't.
Yeah, it is.
But then everybody gets it right.
Just making sure. One of that's internal consistency, that they're on the right form. I guess, so what are the questions about naloxone administration by BLS?
Well, I think the only thing that anybody would need to know is when it's used and what was the outcome.
I mean, the hazard to individuals is important, right? If that happens, we would like to know that. Theoretically, that would be part of the PCR documentation.
Yeah, theoretically it would be, yeah, it would be a narration.
And if they mutual aid in ALS to help, that would also be part of the PCR.
Mm-hmm. And they're supposed to file a copy of the ALS intercept unit with their PCR. Yeah.
How would you find out if the cops gave it to them?
I don't know how you find that out. That's a very good question.
Do we have any parent?
It's not reportable.
Is that?
Yeah, there are a couple of police departments carrying.
A lot of them.
Yeah.
I don't know, I mean, I don't know the purpose of us as a region even tracking it. It's no longer a demonstration project, it's a permanent protocol that's all the way down, and there's no way to track it on the non-EMS side of things. And the regional police department has, and the state has pretty much gone through naloxone training that was offered by, the state or the state police, and they've got these kits. I don't know the purpose of it.
So it might be a little bit dated, this form. Was this form from the demonstration period?
This is the form that Remo was using. Maybe Dean could comment on that.
Because I can see when you're just introducing it, you do research elements that might lend itself to encourage.
Dean, does Remo track this?
Remo does track it. We treat the BLS Narcan just like we treat just the rest of the BLS modalities. So we receive a report every time albuterol is used at the BLS level or EpiPen at the BLS level. So it's just one more of the BLS modalities, and we're hoping to actually standardize the form so that it's the same form with a select the modality at the top thing, so it's consistent amongst all of the BLS modalities.
Mm-hmm.
It's just one more tool in the BLS toolbox.
And so you ask BLS agencies in Remo to complete these every time they use one of those modalities?
Yes, and they're pretty good about doing that. They use it, and they usually get a fax within 24 hours.
So you're going to add CPAP to it?
One more modality.
What do you do with that information?
We collect it. We follow up on the with the ALS agency because it requires some kind of an ALS intercept or connection with an ALS agency to make sure it's appropriate. And beyond that, if there's a positive outcome, we'd like to really recognize that and congratulate the organizations for doing that. Beyond that, we just track it, and we can go back for statistical information if we needed to.
So how close are you to a combined form for all the data?
That is a slippery slope. That's going to be like more of a state thing because there's also other forms that need to be formalized, like the notice of intent for EpiPen, notice of intent for public access to fibrillation. All these things are standalone. They really all need to come together. So the usage form will probably come together within the next year.
So in our region, we don't have forms for albuterol for BLS.
No, we've never tracked that specifically. No.
So we're a little bit short.
Well, might be a good idea to wait until REMA gets their one form for everything, and then we might consider adopting.
Then we'll plagiarize.
Okay. Or we could just give it to you.
Good idea should never go to waste.
Well, it does seem like it's, a reasonable thing to wait to combine this with other. The other thing we could do in the meantime would be if you do pick up, Joyce and you and the PCR use of naloxone. Right now you're saying it's 0.
Right.
We could review 100% of the usage. You could pull all of them, or you could just report 0.
Yeah.
Reporting.
When it's 0, we report 0.
In a similar way, could you also pull out Uterol and EpiPens and CPAPs?
We could. We haven't today. The CPAP, there's another little bullet point about CPAP coming right up here, but which is fascinating, I think. We could do that, yeah, we could do it if it was by other reasons.
The question I have is Dean, how many staff members does Remo have in their office?
We have one full-time staff person, and 2 part-timers, 3 part-timers.
I mean, a majority of the agencies, certainly the bigger agencies that are using EPCRs, while they're uploading to the state bridge, and this was a conversation, obviously, about data collection and what we can pull off of the state bridge and what we can't pull off of the state bridge. The region doesn't necessarily have access, like in Remo, to an EMS charts. You know, Mark is using a different program than we're using. Rural Metro is using a different program. Amsterdam Fire. So for the region to have access to all of this, I mean, they get these forms. There's going to be, are you going to have time to say, okay, well, we need the PCR, we need to go to the hospital, we need to do this. Well, I understand that data collection is important, or, you know, again, it was a conversation on
Well,
what
like
we can
Dean
get
said,
from the state
this
bridge.
could have become a slippery slope in a hurry, yeah.
Well, the original plan was that the region was supposed to have back access to the state bridge to pull out their own data.
Right.
Right.
So I don't know if we do or we don't.
Oh, we have access to the state bridge, that's no problem, but there's only 18 agencies in our region that are participating in EPCR right now. Out of 115, there's only 18.
So you're not getting full spectrum data.
Not at all.
No.
Not at all.
Percentage-wise, it's got to be pretty high.
All right, why don't you
Look at, I
overwhelming
mean, the number of
support for
PCRs
this
generated
forum?
electronically, it's got to be 80%.
So,
Statewide, it's,
For this region. For this
Or-
region, when you look at the
yeah, because-
agencies that are EPCR, I mean,
As soon
they've
as-
got to make up 80%.
Yeah, as soon as Fulton County comes on board, it's gonna be at least, yeah, it's at least 80%.
yeah,
Yeah.
Fulton County's
All the high
still,
volume services are there.
right.
Pretty much.
Fulton County's the last one that's not there, right now. They're coming.
you know, the second biggest provider, or close to the first, it
I can
varies,
give you
but
an
they
idea
are,
of the workflow that this actually causes. So of Remo's 210,000 calls a year, I'm getting maybe 6 to 10 of these a week to process, which is not an overwhelmingly difficult task. And as far as connecting them to the chart, they usually come with a chart if need be. If not, I can access the chart through EMS charts, or if it's one of these vendors that I cannot, usually it's just a fax and they send it to me pretty quickly if I need to follow up on it. However, more times than not, if it comes in without a chart, and I reach out to the ALS agency who connected, and they have already done a review, really the work is done. There's nothing further to
Well,
go.
you know that data, I guess, is that data accurate? Well, what pleases those agencies to do that? Or are
Right.
you just,
that's my concern.
you know, if an agency doesn't do it, you don't know about it, so your data that you're collecting and basically you're wasting your time on because it's not accurate.
Well, it depends on what you're doing with the data, if it's a waste of time or not. If you review the data for good patient care and beyond that, you know, you're not collecting the number of times we have BLS usage like we were in the demonstration project. It is good data because it's really about just maintaining the standard of care.
I think we could do this since we have so few, like 0, that's quite a few. What if the program agency just use this form when they do identify utilization, use this form with that PCR and bring back to the REMAC any concerns you have about that utilization? In other words, you know, they're expected to document how many doses, they're expected to document the times, they're expected to document any hazards to the crew from this form. That would be useful information. I think if there's hazards to the crew, they're running out of naloxone and things like that before ALS gets there. You'd be interested in hearing that.
We can, I feel we can certainly handle reporting from our agencies as far as the intranasal naloxone, the BLS agencies, that's not going to be a large number.
Okay, and the form might be, you know, I don't have a better form to do that review with, so when you pull a PCR, you know, you can just complete this form along with the PCR and say, you know, if documentation was inadequate, then we might get back to the BLS.
Yeah, I mean, I am certainly gonna continue to look. Beth just told me that an agency did use it, and either I didn't spot it, or I didn't receive the PCR yet from them, so I don't know what, when that was used or whatever, but I will pull all the ones that I have, and I can use that form to,
Okay.
fill it in.
Okay.
But it's just a matter of whether, if I spot it, because I can't read every PCR thoroughly.
If we make the form available, this is just for discussion only, but if we make the form available on our website for downloading from the intranasal Narcan agencies, they can submit that themselves along with the PCR when they send it to us.
Yeah, so this form goes so far as to say it is to be completed. This form should be returned. So that we want to put out to BLS agencies that are using it.
I can send an email out to all BLS agencies.
I can certainly tell you it's a nice idea, but from any kind of experience in the past, we're not going to get a lot of them back, even if they do use them.
Right.
The responsible agencies are going to send them back.
Right.
The
I can tell you
majority
there are a few BLS agencies out there that are very, how can I put it? They're very anxious to use this intranasal Narcan. Very anxious, and very anxious to let everybody know after they've used it. So, like Joyce said, the responsible agencies we're going to hear from. The other ones, maybe not so much.
Point of clarification, are we saying just BLS agencies, or are we saying BLS provider administration?
That's what it needs to be, because there
Yeah,
are
it's
multiple
provider.
agencies that are
Okay,
ALS.
so,
that
but,
will
I
have
mean, you're
BLS
saying BLS agencies, it needs to be BLS provider administration.
Yeah, I guess that would be more accurate, yeah.
Sure.
Because there are times that many agencies that are ALS sometimes go with a BLS crew,
Right.
because that's who's available that day.
All right, so the title of this could be the AAREMS BLS Provider Naloxone Administration Plan.
Okay, we can do
All
that.
right. Okay, CPAP statistics statewide.
Yeah, no, this is,
Can I get a little sidebar in here? I got an email yesterday from Mike Taylor saying that you recall there was a problem with EMS charts, and I don't know how many people are using EMS charts.
oh yeah, no,
They have been bought by Golden Hour, and they're gonna honor all their previous contracts, et cetera, et cetera.
I was going to report on that later, Mark. Yeah, it's
Okay.
a most interesting state of affairs.
Yeah.
Most
Stuff
interesting.
people would wanna know.
So if I can give you just a minute's background on the CPAP statistics. Bob Stuber from Finger Lakes Region is spearheading the CPAP demo project.
I
in the
have the
state.
report here, I'll pass it around in a minute, because I wanna read from it.
And he asked AAREMS and Mountain Lakes and Remo, how many respiratory distress calls have been logged in the period from August 1 last year through August 15 this year electronically? And how many of those show a CPAP use? So we did that. I called up Mike Taylor, and he helped me walk myself through the software, which is very sophisticated software. And we're all learning it as we go along, the data reporting I'm talking about. Anyway, in that period, August 1/13 through August 15th of this year, there were 1,691 respiratory distress calls. We're talking severe respiratory distress now, and 79 of them were treated by CPAP.
This is in the AAREMS region?
This is statewide. Statewide.
No,
No, so
No,
the
I'm
AAREMS
sorry, I
AAREMS.
beg your pardon. No, this is the AAREMS region.
Right.
1,691 in AAREMS, and 79 of them were treated by CPAP.
How many total EMS calls are there?
In the AAREMS region?
Yeah.
Oh, I have no idea. I have to go back to the software.
So shortness of breath is like one of the most common reasons people call an ambulance.
right, but only 4.6% of these respiratory distress patients got CPAP administered.
Right.
And that's
Tiny
the
number,
really-
a tiny number of
Yeah.
CPAP administrators, a
And-
tiny number.
And there were no CPAP administrations during the project in this region.
Right. 79 were logged in
That's all another
AAREMS from August 1 to 15.
That's all another
Right, and those are BLS and ALS.
Right, no distinction was made between
Right.
BLS and ALS agencies.
So Dave, you had some squads that were using CPAP, right, or at least signed up for it?
Right, and we had no BLS uses. We've been pushing it for more ALS use. And they've been using it, but no BLS is using it.
Okay.
And then that falls right into line with what we have.
So you have it available, but
We have it available, but there've been no BLS.
It's interesting to see how the state reporting comes out, because when we use CPAP in the city of Amsterdam, there's 2 PCRs, there's one from the Amsterdam Fire Department, there's one from GAVAC, and they both will say CPAP even though only one agency did it, so they count that twice?
I don't know. Good question. But overall, the percentage of use versus the number of respiratory calls, it went from like 4.2% to 7 point something percent. It's very low. And the data for in the pilot program was very, very small. And there's some charts in there. I'm going to pass this around. And there were 4 regions in the study, and then they queried 2 other regions, Monroe, Livingston, and Susquehanna, to see what their usage was, and that was equally low. I'm just going to read this one paragraph. From this data, it would either appear that patients in these regions are either better managed than originally thought, or the providers are not applying CPAP as often as they should be. So this might be the focus of a future study. I'm just going to pass this around because it's very thorough for such a study with such small numbers. It's a very thorough report.
It was for that study precisely, I think, that Bob Stuber wanted these stats.
Yeah.
I didn't hear what Mountain Lakes or Remo's percentages were, but ours was
Well,
extraordinary.
it's in there in
It's
one
in there?
paragraph. Yeah.
ours was 0, right?
We didn't have any BLS uses in the study.
No BLS use, 79 uses, but no BLS.
Nonetheless, the CMAC approved CPAP for BLS
Right. And
with some providers.
AEMT.
Right.
And the question is, do I have to make a request or inquiry about making all of my squads that were participating in the pilot program or the study, as now it's full-time
It's
protocol?
not yet, though. It still has to go before the commissioner to be approved before we can start any implementation.
Right. They want universal training, but it's jurisdictional in terms of whether the region decides to make sure everybody adopts it or not.
And that would be addressed in our protocols.
Right.
Because we would be adding that all the way down to the DLS.
Which is another thing that we need to talk about today, apparently, is whether or not we're going to adopt the collaborative protocols
So
with the changes that we're making.
So CPAP was, the key word was jurisdictional, which we got defined as REMAC.
Right.
So REMAC has to approve BLS CPAP. So it'd be similar to Narcan, albuterol, tablets. All right, so thanks for the update.
We have one more item under other new business, and I'm sorry I neglected to put it in my printed agenda of the discussion and adoption of a uniform complaint procedure.
All right, okay.
Before we get to that, I have one more thing.
Yeah, and I do too. Go ahead.
While we're doing the medical directors, we're in the process, our medical director, Tim Schoen, is retiring. We have Steve O'Krabi as one of them. We're going to take, we wanted to have Tom Ivanovsky, who works at St. Mary's Hospital, as our second medical director. I haven't done the paperwork, I just need him to sign it, but if we can get that approved, I'll get the paperwork to Phil this week.
All right, Dr. Fisher apparently knows the names of the people you just mentioned. Is Dr. O'Krabby still working in the region?
He comes up frequently.
Any opposition to that? Okay. All right. So let's take the new since let's keep on the sheet for a second and just do old business protocol feedback. So the collaborative protocols were approved for REMO at the last CMAC, and the state made clear that we and Mountain Lakes and the other regions that use those protocols need to individually send a letter to EMS at the state saying that we also adopt that. In other words, REMO couldn't accept on our behalf. We have to accept the collaborative. So, and the collaborative protocols were sort of a moving target during that meeting. They had like three addendums and some friendly amendments, and I'm not sure what actually came out in the wash. So I think what we should do, and I saw you electronically sent out what you have as the latest version. How recent is the update to the collaborative protocols? Do you know, Jane?
It doesn't have the amendments from CMAC.
All right, so we should wait for that, I think, because there are a bunch of things in there. Intranasal, fentanyl for children, a few other things that kind of went over the dam at the last minute, and we haven't really seen it in the print, so we can't approve the existing protocol.
Is
It's not the final
Is
protocol.
REMO going to actually inculcate them into the format of the collaborative protocol?
Yes, I believe so,
Okay.
yeah. So the problem, we can look at it, we don't have to accept it as is.
I don't know if anybody got a chance to read the revisions or not. I just want to highlight one thing that was a point of discussion there. I don't know if it would stand out more in a region like ours or a region like Mountain Lakes where there's more intermediates or possibly AEMTs. Statewide, there was a decision to keep adult intubation for AEMTs, and it was in the protocols, the collaborative protocols, up until last REMO meeting, and the REMAC decided to remove it at the last minute by a vote of their physicians. So I believe that change will be found in there. So anybody who's an intermediate who's coming up to AEMT or has gone through the new AEMT will essentially be trained to intubate, certified by the state to intubate, but then not allowed in the region.
That was changed.
That was
the topic
changed.
of discussion.
It stayed in.
With those approvals, because it's in the curriculum for AEMT, I think they put that in there for AEMT.
It stayed in.
Well, that's
At the CMAC meeting, it stayed in.
At the CMAC meeting, it stayed in,
They made him change it back.
because it was in the curriculum and there was too much confusion.
It stayed in.
okay. Well, I feel a little sheepish sitting on the protocol committee and not knowing that then.
Why did they want to remove it?
I
In the intermediate portion,
Yeah, it doesn't conform to the national curriculum for intermediate. So it's a New York,
But New York intermediates can't.
right.
But New York intermediates are going bye-bye.
That's right, but they may go to AEMT. And so there's a skill that they've had, and now can they use it or not? That was the question.
So I think that, so the state preempted the protocol in a sense, because they had decided yes. And I think the protocol writing committee at REMO was unaware of it, that was actually sort of gospel truth from the DOH, and so they didn't put it in their protocol. Because they were following I think the national curriculum, trying to point to that. Because this was an attempt, right? I mean, we adopted AEMT in that language. It was an attempt to move New York closer to sort of national standard curriculum.
Right.
And then this came back as a New York modification to that.
I have a question regarding that. On the protocol draft that we have now, under the respiratory airway obstruction, our old protocols, the CCT and the paramedic were the same, but in these, they stopped the CC from giving Medrol, and now it's just a paramedic. Is there a reason for that?
I don't know. These are specific protocol questions that should be surfaced to the REMAC, which you're doing. So we can take a look at that. I think I'm a little bit reluctant to start reviewing what is a protocol that's in flux. This is not the final thing that came out of the CMAC. So I think as soon as we can get that, all those revisions embedded in the protocol, we can take a hard look at it. We have until January, right? So between now and January, we should decide whether we sign on or sign off.
Am I correct in saying all we have to do is just write a letter to the CMAC and say that we wish to adopt these protocols? Is that
Yes, if we don't change it and if we don't have exceptions in our
The biggest changes that I saw was it introduced and adopted the AEMT protocol, so they would have a scope of practice.
Right.
It took out the intermediate scope of practice.
Right.
It took dopamine out and put norepi in, took nitropaste out, slowed down our mag drips.
Put Haldol into it.
Put Haldol in.
And broaden the use of ketamine.
Broaden the use of ketamine, and added the intranasal fentanyl for children. And that was pretty much the summary of what I got out of.
Remove nitropase in the respiratory.
I said that.
Those
What
about
about
six-
nitroxoxide?
And change
Those
it
are-
And then
to
nitrous oxide.
dextrose.
Yeah, change the word D10 to dextrose, because Tom brought up that there were some difficulties in getting D10. So it gave you the ability to use D10 or D50 if there was substituting D50 and if there was a shortage.
Except in pediatrics. Pediatrics require D10.
D10.
You
So-
also put in Levofed back in.
And took dopamine out.
Right.
And then cleaned up some quantities of how much we have to carry in terms of like reduced glucagon, Lasix. So there were. It was a cleanup more than a total rewrite.
So why don't we do this, Phil? REMOs should be revising the existing collaborative protocols, right? Which they've been approved for by CMAC. Once those revisions are like, the ink is dried, can we distribute them to the REMAC in this council and then
Sure.
maybe devote a future REMAC
Sure,
to
I can,
going through them line by line, blow by blow, and then after that, we will either agree in total or.
Okay.
No, my understanding is they're gonna change them again in January or whenever the AHA, the new AHA guidelines come out.
There will be, the committee is continuing to meet, and they're going to work on the total rewrite of
The American
So
Heart
this is
Study.
the immediate.
the whole document, and incorporate the American Heart. And so this was just a kind of a cleanup rather than a whole rewrite. There's lots of discussion about end-of-life protocols, things like that that are
Right,
going
well,
to
the
be
protocol that was approved is effective January 1,
for them.
right?
You could choose a different effective date as a REMAC, but I mean, I know that for myself and probably for every other agency, if you wait till November and then 6 weeks later is your rollout date, we got a lot of work to do in terms of education and inventory and
So the
stuff
sooner
like
the
that.
better. So as soon as the ink is dried, we should distribute it and just
I'll do that.
go, and not assume that everybody's read the protocols, and just
Okay, hold up,
go
right.
through it blow by blow. It'd be good to have somebody from Remo here if we could, because they have, well, you guys gonna be here? I think as questions surface, right, those questions might have surfaced at Remo. We could sort of get the logic of that.
Dean, do you have any idea when they might be ready from Remo?
I do not, only
Okay.
because the state meeting was last week and
And so the same is true, Mountain Lakes has to go through the same approval process.
Right.
Gus, procedure-wise, if the region chooses not to adopt them, does that mean that whatever modifications this region makes needs to go back to CMAC
Yes.
before?
Also means we'll owe Remo for all their hard work.
you as a
The non-collaborative, collaborative protocols.
Maybe Scotland's voting today.
If I go to the physician, Phil, are you going? Do Fowler used to go, you have to connect.
What?
I'm just seeing what the physician connection is, if any, to the physician group. There's quite a few physicians on that protocol writing committee,
There was physicians in attendance that were in disagreement with that meeting.
so they didn't have 100% consensus. So,
Probably be good to reach out to Dr. Doynow.
yeah.
He practices in both regions and is chair of the academic at Remo.
Well, it'd be good if we could conform to the, we have to have pretty strong reasons to disagree with it, otherwise we're going to be off on our own again.
Right. The collaborative will have to be put in quotes.
Yeah,
Collaborative,
formally, the protocol formerly known as. Okay, so but we do have limited time
Okay.
to turn it around.
I will
So
keep
the
on it,
sooner we
as soon
can
as I
get
get
a
them, I'll
letter.
shoot them out to everybody.
Okay. All right, so back to Phil's other topic, which is the
Claim procedure.
Senator draft titled Complaint Procedure.
Now, this is the, what I distributed, what I sent out to everybody on the 16th, well, excuse me, on first. And I sent it out again the other day. This is essentially REMO's complaint procedure. The only modification is to change names and titles and so forth. And there was I'm recognizing a little difference in REMO's structure versus our own. But Tom very kindly assisted with that change. So the flow of the complaint procedure is the same in both REMO and this proposal.
So everybody should take a close look at this. This provides a structure, which right now within AAREMS I think is kind of informal. Kind of stand around in a circle in the executive session.
We do have a written complaint procedure, but
This would be a further enhancement.
this would be it.
This would be an adoption, replacing our present procedure. But it does bring us into uniformity with REMO.
So what couple observations. One, the term accused, it has a very legal, so, you know, in my shop, when a nurse or a PA or a physician gets a complaint, I don't refer to them as the accused.
Okay.
I don't know what else we can, recipient or whatever, the named individual.
Named individual,
or individuals. The other thing is that this straddles Article 28 and Article 30. When you start naming nurses and physicians, and then suggest that the AAREMS Board of Inquiry is going to sit that nurse down, or sit that physician down at their Board of Inquiry and render an opinion about whatever it is that they did, I think hospitals would take umbrance with that.
Okay.
This is Article 28 facility, this is Article 30, we're in the Article 30 world. I don't really have any jurisdiction in Article 28. We can.
This wording exists in the REMO, and that's why I included it here. It exists in the
just
REMO
like we have nurses around the table. I think that it's not, you know, an unforeseen circumstance that a physician or a nurse comes onto EMS radar for some behavior or protocol violation or ignorance, and we might want to bring it to the attention of their institution, which is fine. It does mention, you know, bringing it to the attention of the institution. But I think for physicians and nurses, unless they're practicing in the field, I mean, if they're field providers and it's a field issue, then I think it's kind of a different animal. But if they're within a hospital and, you know, they did something at the bedside or said something at the bedside that was registered, was sufficient enough for the EMS to register a complaint about it, I don't think we should be under the impression that we have the authority to direct that nurse or physician to come before the AAREMS Board of Inquiry and hear it out. I think I would rely on the medical directors of those hospitals and emergency departments to be informed. And we could ask for, you know, a letter back from them, closure, the same way we do now with service medical directors, right? Mm-hmm. So if we have a medic who comes on radar, what we do now is we correspond with the service medical director and hound them until they respond to us. I think that's sort of the limit of our ability to do things.
How should that wording be changed, do you think, in the first paragraph then?
Just cross off nurses and physicians.
Yeah, I would think that would be, I would just stay within the realm of Article 30. That's my
The question, I think that the reason why it's in there though, is it does specifically say involved in pre-hospital care. If you follow that line down, it's not saying in hospital care, it's saying in pre-hospital care.
Yeah, well, online medical control, that's pre-hospital care, delivered from the hospital. Right, and Also, the transitions in the ED, for example, when EMS hands off to the ED, it's actually, that's sort of the borderland between Article 28 and Article 30. So there could be issues that arise there. I think we need to air them, but I think the appropriate board of inquiry, if you will, is the hospital.
Does each hospital has a specific plan on that? Most hospitals have a specific plan. If you have a complaint, you put it in writing and give it to the director of that unit or something like that. Most hospitals have a specific plan for that. And you call them up and tell them you have a complaint, they'll tell you, put it in writing and address it to so-and-so, and then they take care of it.
Right.
But I don't think that we're disciplining nurses and physicians. Why can't this REMAC be that person to fill that complaint in? I mean, as EMS agencies, we could.
Well, I think it should be done from the individual and the agency. If they've got a complaint, they're the ones that should address it. Because, as Dr. Leinhardt said, this council doesn't have any authority to discipline or.
But you're not disciplining. You're bringing it to the attention of that facility.
Right.
And as an online medical control physician, or someone that you're handing it off that involves EMS, I would think that the REMAC would want to play a role.
Well, I think this policy is fine up until the point where the Board of Inquiry gets activated. So all the way through this, it just says you're going to notify the agency and institution, right? Mm-hmm. And for the physician and nurses, I would say that's sort of the end of the line, except for expecting a reply from the institution that the complaint has been received, and we'll take it from there.
I believe this issue is addressed in our current policy in some way. And we can go back and look at that.
The question is, do we have a policy? Because when we sat in the executive sessions and we went to bring these issues forward, it was unanimous that there was no policy in place and we couldn't do a thing about it.
There's a policy in place.
Maybe what we should
There's
do
a complaint policy.
is pull the existing complaint, AAREMS policy,
Okay.
and then send that out. We have this.
As far as I know, there's a policy.
Okay.
Okay.
I just have the medical control plan with me. I don't have that with me, but I will look it up.
Is it on the website, the policy?
No.
I don't
it's
think so,
not on
no.
the website. No, it's, I think we probably have it in the computer. I'll look at, when we have a lunch break, I'll take a look in the computer. I believe we have it there.
There's a question over here.
What if the issue is with a physician on scene and not necessarily from a hospital in the region who refused to sign your paperwork or anything?
Right. That would come to REMAC, and we would have to engage that physician.
Because we have an intervening physician policy in our protocols.
Right.
In the Board of Inquiry, just to, if it's deemed necessary, that's the only time that board is formed. So if the REMAC doesn't have an issue, or that physician or nurse does not fit where the REMAC would be acting, then they would not create that Board of Inquiry.
Right. Yeah, it depends on the scenario you imagine, right? So if you imagine a field scenario, it'll probably be handled by the REMAC with that individual physician. Mostly to educate them. I mean, the way physicians can get into trouble is they don't understand what arena they're in, and they're making decisions that may impact EMS providers and sort of offline medical control. The other dimension that the REMAC does have is service medical directors. Right? We approve service medical directors by law. So if there's a service medical director who thinks that intermediate should be burr holes, we might want to call them. So it really depends on what the scope is. What do you guys think? Physicians that are remaining silent at the table over there?
I think this needs further investigation.
Okay, all right, that's good.
How do the nurses get involved?
I don't know, you can imagine scenarios where EMTs might have an issue with what nursing does.
That's like a handoff, but not out in the field.
Well, we've had the issue out in the field a few years ago with the nurse going out in the field, starting IVs and putting the patient in the ambulance, and the nurse goes on and ambulance transports the patient with an IV with a basic EMT. We had that issue a few years ago.
Yeah, so it's like scope of practice, and
Yeah.
so we would bring it to their employer, assuming they have
Are
an
they on
employer.
duty, or are they just doing this on the fly? I mean,
Well-
are they on duty for the hospital, or on duty for the agency, or
No,
who are they
well,
working for? when they're
she's
just
a
out there?
basic EMT, but saying, the basic EMT is saying that because she's an RN, she can start an IV out in the field, and you can't do that.
That's not,
That's a whole different
that's
issue.
against the law.
Right.
That's
Then you
not-
bring her up on the EMT portion here, and her role as far as what she should be doing.
Right.
And then you bring her forward, not as a nurse in this arena.
All right, so if there's an existing AAREMS policy, I'm going to circulate that. We can put our minds back to this and give it another go.
That's a question that I have. I know of two complaints that are specifically waiting for some kind of policy, including one outstanding, quite honestly, that we put off as a REMAC, at the beginning of summer, that we chose not to address. How long do you let these complaints continue to fester, and how long do you hold them until a procedure is in place? And, I mean, literally, this is a REMO document other than changing it to say AAREMS, adding the words program administrator as opposed to whatever Tim's position is, executive director or whatever else with REMO. Why wouldn't we want to sign on to the same thing and replace, even if there isn't an existing policy, why wouldn't we want to update it to fit the needs of our current protocols in the system that we currently practice in?
I think if there's a question about jurisdiction, you have to be very careful about not exceeding your authority by law. So I think Dr. Leinhardt raises a very strong point that you may want to look at that issue before you just blindly adopt this.
As far as nurses and doctors?
Yeah, and that whole issue.
If we take the nurses and physicians out, and we change the accused to the individual name, that addresses everybody's concern, at least to put a temporary policy in place. Those are the two questions that have come up, whether or not we can address nurses and doctors. So,
Yeah, I agree. Now, just because I said that this is addressed in the current policy, the current policy, as I remember, is quite complicated. And this one seems to be a little bit more general. So, I mean, I see no reason why we couldn't replace the current policy with this one. But the only reason I mentioned the current policy is because I believe it does address issues with medical control and nurses and physicians and so forth, so, if I remember correctly. But
I honestly don't remember, it's been quite a while since.
yeah, it's been
the
quite a while
policy was
since
adopted,
it's
and
been
it was put on the shelf,
unearthed.
obviously.
I'll dig deep.
It's always fun to dig deep, come up with some interesting material.
well, I would make the motion that we adopt this policy with the amendments of removing nurses and physicians out of that first paragraph and changing the word accused to the individual name.
Individual or individuals' names, actually. Would that make more sense?
Just take nurse and physician out of all.
Yeah, if we remove nurses and physicians from all of them.
And so there's motions or a second for that?
I'll second that.
All those in favor?
Right.
All those opposed?
Just a doc's vote, don't they?
It's a position
I think
vote.
the physicians
The physicians have the final vote and REMAC.
would like to see the existing AAREMS policy.
I'm sorry, I didn't hear.
The existing AAREMS policy. I'd like to see that.
Hey Gus,
Yeah.
dig deep, you probably have it somewhere.
Okay, so that's, any other business?
Yes.
I have one. It was brought up at CMAC that there's recent literature about therapeutic hypothermia, that it really has no effect on survival rates. And they passed a motion that regions wishing to discontinue therapeutic hypothermia must advise the Bureau in writing. And Dr. Cushman from Rochester noted that they have already pulled field therapeutic hypothermia from their practice. The hospitals may be doing it, but the hospitals apparently there requested that they would like to do it only and not have it done in the field, because apparently patients really don't get much of a drop in temperature. So that's an issue for the REMAC to decide at some point.
What are the protocols saying now?
The new protocols, I have no idea what the new ones are.
It's removed it in the new protocols.
I'm sorry, that's what to say?
It has removed the the therapeutic hypothermia after ROSC has been removed from the new collaborative protocol.
Well, that's pretty definitive.
REMO removed it in May. REMO put out a REMAC advisory to all providers saying, don't do it no more.
So it's in the existing protocol.
It's currently in the protocol until you as a REMAC make a motion on it to say, don't do it anymore, and the state is asking that if you say don't, it's okay to say don't do it anymore, you just need to send us a letter.
Yeah, it's in the draft of the new protocols too.
It is still in the draft.
It's still in the draft?
Yeah.
That was probably
For
early
basic
on.
EMT. It's ice packed, actually blind, and that can change every 10 to 15 minutes.
All right, so it sounds like we need to send a letter both to agencies and the state saying active cooling of patients after return of spontaneous circulation has no evidence for it and should be ceased. Any objection to that? Further discussion? And then whatever we send to agencies, whatever we call this, an advisory, whatever, from the REMAC, copy the state.
Didn't he just say it was still in the draft of protocols we received?
We did.
Yes.
So
That,
do you want to wait until the,
No.
It has been removed.
it's been removed.
okay.
Yeah, that's a predated version, so it precedes May.
No, because in May, we discussed it in May, when they removed it then, you said you would wait to see what the state said.
Yeah.
The state's obviously being passive about it, and they're wanting to relax themselves.
At what point do things like this become collaboratively done through the protocols? Like, if we have a protocol change, do the REMACs individually change it, or should we get together through the committee and then have the REMACs vote?
Yeah, I mean, I think in the eyes of the state that we're an independent, home rule kind of region. That's why we need a letter to say we adopt those collaborative protocols. So it does make for challenging revisions as things like that occur. We could have done it in one fell swoop, but we didn't.
I think there's a chance to still do that.
And going forward.
With the exception of Remo, who pulled it already.
Yeah.
And as I said, REMS.
Because, I mean, we did that. So, I mean,
Oh,
how
yeah,
many other
no,
regions? We've got, what, 5 other regions in the collaborative protocols? That's
I don't
what,
know how
7?
many regions are involved now.
There are 6 regions right now that are brought into the collaborative protocols as of my
Does
last
that include
look.
Monroe Livingston? No.
No, Monroe Livingston is not, but they were the first REMAC to issue an advisory saying cease.
Okay.
Just be nice to, when
Work
stuff like
together,
this
yeah.
comes up,
Yeah.
have a way to handle it collaboratively.
Right.
Just to give you, since we're talking about protocols, I'll just mention very briefly the Android format for our collaborative protocols is out and being beta tested, and I'll have more of a report this afternoon, but it looks nice. It looks nice. There's 6 people beta testing it. Apparently only a couple of us have sent some information into the, whoever the developers are. They're out in California somewhere. And we found a few glitches, obviously. That's the way you beta test something, I guess. But it's going to be very helpful. Very, very helpful. Got some neat conversion charts in there. You can just a couple of taps on the screen, and you can find out, you know, what's centigrade, what's Fahrenheit, what's kilos, what's milligrams, everything. You know, the whole works.
Any other business?
Yes.
Go ahead.
No, go ahead.
I just, one of the things that is frustrating for me as an agency is we adopt these collaborative protocols and we work, or should be, working hand in hand with agencies such as REMO. While I understand we're a separate, organization and a separate REMAC and everything else, we either need to buy into a system or we don't. REMO has now changed their protocols. It has been approved. Even at the state level, why are these protocols going through as individual REMACs as opposed to, again, collaborative protocols? Here's the agencies or the REMACs that have signed on board, or regions that have signed on board, AAREMS, Mountain Lakes, REMO, and standardize things. That was the goal of this entire process. While I understand that there are some conversations that take place, maybe we should approach REMO and find out how this REMAC or individuals from the region can be part of this to work.
Yeah, I think it probably could have gone down differently at the CMAC had REMO approached it with the other regions pre-engaged. So what was brought forward to CMAC was REMO. That's what got approved.
Right, as
So the
opposed
state
to
said,
the collaborative.
Right, but so it implies that there's other agencies like AAREMS yet to come forward, and the state wants to see evidence of that. So it could have been done collaboratively after the CMAC had all of those 6 regions signed on prior to that meeting. They could have all been there at the same time, and that this is REMO, this is AAREMS, this is Mountain Lakes, this is, I don't know.
We could have all come to the table
Hudson
once.
Valley,
And
yeah.
how do we get to
could have
that
all
point? I
done
guess
that.
as an individual REMAC, how do we get to that point? At least with REMO, an agency like myself who goes into REMO territory frequently, and operates. It's crazy because we're not doing the same thing. As of today, our expanded use or use of ketamine isn't there. Levofed is not there. All of the things are different for this region. So I think that we need to make it a priority somehow to work more closely with the REMO region.
Well, those, I think, REMO's.
Sounds like you just volunteered to go to those meetings with them.
It's not even that, because I totally agree with what you're saying, Tom, and I'm active in 3 of the regions. I think the intent of it was great, but I think if we're not really careful where we're going right now, we're going to end up with, states seceding from our nation, so to speak. And I think part of that is that, right, part of that is that the original collaborative protocol committee was a group of people that were sitting down face-to-face and meeting, and it turned into some electronic meetings out of ease, and it maybe lost some representation across the board.
Well, here's the craziest part, is I'm going to just take one protocol, excited delirium. Guess who the agency is that got excited delirium protocol changed and Haldol put in? Us. Why? Because we did an electronic music festival in which we couldn't, that was the only way we could manage our patients and control safety. Guess what agency can't use Haldol?
Right.
Us. It's crazy. It's a crazy system.
Well, just remember, we hadn't been here until we adopted these protocols, and then we took it out.
I agree.
And same with us. We're spread over 2 regions. And one of the best days of my life is when REMS signed on to, my professional life was when REMS signed on to the collaborative protocols. I didn't have to think down 2 channels. I went to one channel.
I think Tom makes a very good point, but nobody has been stronger about collaborative protocols and statewide ALS protocols than Dr. Leinhardt for years. And this seems to be a good way to do it, and I think you raise a good point about it. But there is the home rule issue, and I think the department wants to make sure that each of the regions is in agreement in some way or other that's definitive and clear. So I think that's part of the issue.
I guess
as well.
if we had been working together, even though it's a home rule, we could have approached the CMAC the same day.
And part of it also is how infrequently the state council is allowed to meet, and CMAC is allowed to meet, which is
The thing
very
that comes with that though, Mark, is as much as the providers always outnumber the physicians in the room, it really is the REMAC of each region that needs to work collaboratively with each other and have a good showing of the providers who are actually doing it to make sure that they're making good decisions for the providers to provide the care.
Well, you know, in the process of making this more collaborative and these issues come up, that's how we make it more collaborative, and I think you're right.
I guess the question is, which protocols are the collaborative protocols? Because we are labeled collaborative, and we are, I guess, with certain regions, every region but Remo, and then Remos are labeled collaborative, but the only region that's in that collaborative protocol is Remo.
I would suggest there be some firm but polite communication to Remo about this, and maybe you can make some progress.
How would you suggest doing that, being the guy who sits in both meetings?
Get Dr. Daly in a room and box his ears.
That'll get you nowhere.
Yeah, I mean, it's sort of, it's the pain that comes with the joy of having collaborative protocols.
That's
It's
right.
like, how do you coordinate those 6 regions that move together so that when you go to CMAC, it's...
I mean, we're not in Westchester.
But that's how you do it. You work together and you don't make a change. You don't make a change until everybody's talking.
Right.
No unilateral movement.
Right.
What happened to the initial group of people that were tasked to design these collaborative protocols? Is that just...
No, it exists.
Right. Is that, I mean, should that
In
be
a
tasked to
virtual
them to
world.
continue to...
Yeah, but they
monitor
exist
and
in a
maintain
virtual
that
world.
way?
All regions are virtual. But, so right now, we're in a place where,
The daily land.
well, like for example, Mountain Lakes was not at CMAC, right? And Remo was suggesting, sort of as the water was going over the dam, protocol changes to their protocol. That got approved. So it's like, well, Mountain Lakes wouldn't even there. So it does have to go back. So I think that's another feature of this particular scenario we're in, is that the protocol we're looking at is obsolete. We have until January to see the revisions. And the sooner we can get back on board or not, you know, the dissolution of the union would be awfully quick if we decided not to, or we press, you know, if we think changes are needed, we have to go back to the collaborative and press for change.
In Hamilton County, we got 3 regions. We got Mid-State, Mountain Lakes, AAREMS. So we got people.
Well, Mountain Lakes and us are the same, theoretically.
And Mid-State has been involved with the discussions, the virtual discussions. There have been Mid-State representatives there.
Got their own ballgames.
So I think the sooner we can see the most recent REMO-approved protocols that are due to be effective in January, we can look at them here, and we should think twice about deviating from those.
Right.
But we may have regional differences that make us deviate.
Can I just get a confirmation of what you did today with the ROSC protocol, therapeutic hypothermia?
It's in the protocol now, and we said cease and desist, no active cooling of patients.
Okay, the new protocol revision that came out said no more chilled saline, but it still has you putting ice packs in the axilla and groin. That's the question. Do we follow? Is that what Remo does currently? Do you still have the ice packs, but no chilled saline?
Or was that an oversight?
Or was that an oversight and was never pulled out?
There's no
It was not
active cooling.
yeah, it was no active cooling. It was not specific to one or the other methods. It was no active cooling.
So maybe that's something we can bring back to Remo and say, we got to pull that.
Because it also refers to a fluid bolus, but it pulled out the fluid bolus when it pulled out the chilled saline. So there's problems with the new draft.
So that's why I think the sooner we can get the most recent revision, we can spend the next REMAC doing nothing but going through. Because we do have time to suggest to the collaborative that maybe there's some omissions, maybe some oversights. I mean, the advantage of having a larger group is that you have more people looking at the same thing.
Correct me if I'm wrong, but REMO's protocols, they approved them, but they are not going into effect until January?
Right.
Okay.
All right.
We have one that we'd like
This
to
is
bring.
probably what, New York and Virginia were like after the union was formed.
Right.
Dr. Langer, the REMO advisory from this year states that patients should no longer be given chilled normal saline, nor should they have ice packs placed in the axilla, groin, and neck following return of spontaneous circulation and cardiac arrest.
Yeah, so it appears in the protocol, but that kind of overrides. It's really,
Just when you
cross that out of your protocol. So what are you distributing, Beth? What is this?
What I'm distributing is, CMT would like to ask the REMAC for a variance on the collaborative protocols for CMT. CMT carries midazolam 5:1 per protocol. We also carry midazolam 1:1 for use in our interfacility transport realm.
What is 1:1? What's 5:1?
The concentrations of the milligrams per milliliter.
So what's the concentration?
The concentration in the 911 arena is 5 milligrams to 1 milliliter.
Oh, okay.
Okay?
So I would normally write that 5 milligrams
Okay.
/ml.
Okay. What we're asking is that for in the case only of pediatric overdose toxic exposure, pediatric procedural sedation, and pediatric seizures, that we be allowed to use the 1:1 concentration for safety. To calculate down to what is needed for the pediatrics with the 5:1 is a very slippery slope in terms of calculations. A 5 kilogram patient with 0.05 milligrams per kilogram order gives you down to a 0.25 milligram dosage. And we have pediatric patients that this is a concern for. It is not a new medication to us. It's a medication we have. We don't need to train a new med. We're just asking, and our medical director is on board with this request. Dr. Doynow sees the safety in being allowed to do this. We would remain with the 5:1 the 5 milligrams to 1 milliliter midazolam for the rest of the protocols as outlined.
How can you ensure patient safety that they're not going to grab the wrong vial? Is the concern that was, when this was identified, that still exists.
That's why they want one concentration of all the medications. That's the exact reason why they don't.
No, but they're saying they will continue to use the 5:1. They're still going to carry both doses.
Right. The whole reason why it was made was just carry one concentration is that fusion thing is taken out. And that's kind of national. They're doing it in emergency rooms and hospitals, trying not to have variances in doses like that.
No, I agree. I'm not arguing that point. But when this was brought to our attention before at the health department, that was our question. How can you ensure that there will be? So we said you could carry the 1:1. We made an acquisition and said you can carry the 1:1. It has to be specifically labeled in a separate unit or whatever for interfacility transports to prevent a middle of the night a medic picks up the wrong one. We didn't want to see a provider get in trouble. Or a patient because of a provider error. So if you're going to switch and have 2 doses, the question comes back, how can you ensure patient safety?
It's packaged and and labeled separately, is that right?
That is correct. It is packaged and labeled separately within our box at this point.
But it was only for inter-facility transports.
Mm-hmm.
Now you're saying you can use it for 911 calls.
And both versions are on the state formulary,
No, 5 to 1 is on the state formulary.
Right.
so don't we have to have state authorization to add a medication to the state formulary?
We allowed it in the narcotic plan as long as it was for inter-facility only. I really have a problem with this because of patient safety issues. And that was the argument last time. If you're going to use it for EMS calls, there's a greater chance. I mean, inter-facility, you're on one mindset, you can go this way.
The thought process was, and we have Dr. Dornow's support, simply for the dosing in the pediatric patients, instead of drawing up 0.05 milliliters of the 1-to-1 for that 5 kilogram patient, because the substance was already being carried, use it in those very isolated instances to alleviate some of the potential for dosing errors. If we do not get REMAC approval, we will continue to use the 5-to-1 as everybody else is, but because the substance is being carried for the safety of dosing.
I can tell you that the state will not approve this B&E on a patient safety issue. I had a fight to get that through because we made you label it separately in a separate bag only for inter-facility. It's a safety issue. I don't know what the
I think we probably agree, the whole deal is you want to keep one concentration. It statistically creates a higher chance of making an error.
What about the other side of it, though? If you're trying to deal only with 5-to-1 and you've got a pediatric patient, you have some fairly complex calculation to arrive at a dose.
You're correct.
At ODART 30, that might be fairly error. I think that's that side.
I agree with that side also, but there's a national move not to be doing this, so I don't know.
How about putting a dosing chart for pediatrics right with the medication so that you have it pre-calculated to certain.
And that is the alternative. It just is a thought, because the substance is there to be able to use it so that we're not doing the mathematical calculations, because I think as much as you can identify a risk of grabbing the wrong substance, I think there's a much greater risk of coming up with improper calculations when you have a safer alternative available to you to draw that up.
They both require calculation, there's no
They do.
escaping that. I like Joyce's suggestion of, simplifying it. If you're given one concentration, a table that says kid weighs X, Broslow, right? So, but Broslow tied to that concentration. And that sort of takes the thinking out of it. Broslow is designed to take thinking out of it, so I think something like that. And I agree with Dr. Fisher that the deaths, the legal cases where emergency departments where children die has to do with having 2 different concentrations. And sometimes the pharmacy will make a switch on you. This probably happens now with EMS. The pharmacy doesn't supply what's indicated by the formulary, you get something else. And so there's no escaping the need to be calculated and clear about it. 0.2 mLs, it's not impossible. There are syringes that are 1 ml syringes. So it's just a matter of grabbing the right syringe after you have the right calculation. And I think it's a little bit of a slippery slope too, because this is just one drug. We could do this with every drug on the formulary. Live with that.
We just ask for consideration, and if it's something that the REMAC,
Yeah, I
there's,
think
So abide by what the next thing is.
yeah.
Interfacility is a different scenario, right, where you may actually be going down the road with a drip or something that the nurses may be going with. Any other business for the research?
Just the feedback, I've been texting back and forth with Dr. Daly. The protocols are in final draft, all except for the norepi drip chart. He will email it to you as soon as they're done.
Okay. Any other